Welcome to those who've joined. I'm conscious of using your time well, so it's just gone past 6 o'clock, and I think it's important, 6 o'clock my time, and I think it's important we make a start. Others might join as we go. So to introduce myself, my name's Amy Gray. I'm a professor in the Department of Paediatrics at the University of Melbourne and the head of this department. I'm a pediatrician in I've just lost my share. I have always been passionate about education and have done education qualifications alongside my PhD and my research degree. And I really believe in, I guess, workplace education. So that is, how do we make the most of the education we do in our work and ensure that those people that we have around us, whether they're medical students or trainees, or even sometimes peers, how do we make the most of their abilities and get them to improve in the most effective way? And I'm here tonight to talk about something that's close to my heart, and I think something that we all deal with every day in hospitals, but sometimes don't think about so much, and that is ward rounds. My agenda today, and you'll see in a second why I talk about agendas, is to get you thinking about ward rounds and what happens in your context, to maybe rethink what you think is possible, and maybe have a few new tips and tricks to get into your toolbox that you can use in your day-to-day work, whether that be in ward rounds, in outpatients or in other clinical settings. And I'm going to emphasise that I'm talking about ward rounds today because that is where this work came from. Maybe working in different clinical settings, and what I've realised is everything that I'm talking about today is relevant in those other busy clinical settings as well. So even if you're not intimately involved in ward rounds, these principles will apply to you teaching and learning in other places. And as paediatricians, I think it's really important that most of us are passionate about education, and most of us are passionate about getting the most out of the people around us, and I'm hoping that I can help you along that journey. So to make a start, why ward rounds? My interest in ward rounds began in my own hospital, and I put this up because when I started to look at ward rounds, there was some questions around, are ward rounds still the right thing for us to be doing? Do they still have a place in a busy hospital where people are challenged by just delivering care, let alone education and training? And I found this wonderful quote, is the teaching from a paper that was written on this topic, and it says, in this age where there is much emphasis on science and technology, and when laboratory and computer aids are so readily available, we should never forget that our first place is at the bedside. While I read that out, I'd like you to think in your head how long ago that was written, and I'm not sure any of you would have guessed it was in the 1960s. So even then they thought technology was advancing and this was getting tricky and this was getting hard, and yet I don't think since the 1960s that many people have rethought or thought about ward rounds. And so I got really interested in thinking, what are we doing in this space? What do we teach each other in this space? And what do we do with each other in this space? And what could we do better? When we think about it, ward rounds have changed a lot. Whenever I speak to other clinicians, I'm always told that we're busier than ever, that our patients are more complex than ever, that the other tasks that we're juggling on ward rounds are different to what they used to be. And in my hospital, you can see that in the picture in the right, we have computers and electronic medical interruptions from about. So even as we make these advances in the kind of technology that supports us in our work, that actual work gets complicated. So about 6 years ago, I was asked to look at ward rounds in our context. And I want to tell you this as just, I guess, for background, to understand that what I present to you today comes from a place of thought and a place of analysing ward rounds and thinking about them and thinking what we should do better. My department challenged me to look at ward rounds and think, that is primarily where we're teaching and learning, so what can we do better there rather than what can we add to our day in terms of another teaching session or another way to teach. And so we looked at ward rounds and we did 4 things. We looked at the evidence. What's the evidence for teaching and learning on ward rounds? And just like we would look at the evidence for treating pneumonia, is there something we can apply in our practice? We observed ward rounds, and that was the single best bit of professional development that I've ever done in my life. I spent 3 months watching all my colleagues in this hospital, not to medically, but to think, how are they supporting their trainees and how are they doing that work? We surveyed consultants and we surveyed our trainees to get their perceptions of rounds. And we went even further with another piece of work and started to look at what parents of our children who we saw in rounds thought. I'm going to start with the parents, because often that's not where we start. Although the parents and the patients are the core of our work, we often sometimes think about what they think later. We actually interviewed 100 parents, both of surgical and medical, and asked them as a starting point even what they thought about ward rounds, before getting into what we thought about the education on rounds. This was in our tertiary paediatric hospital, so that might look different in a different hospital. And it was, we have a fairly educated population a lot of the times in our hospital, so maybe that's a bit of bias. We had 50 of those patients from surgical teams and 50 of those patients from medical teams, because we suspected ward rounds look different for each of those teams, and what parents might tell us might look different as well. And this is what they told us. They actually, almost all of them were satisfied that education happened on ward rounds. That was their starting point. Are you even happy that we do teaching and learning on ward rounds? And the vast majority of them said they were satisfied. I think it's important to recognise that there's a small group that don't want teaching and learning on ward rounds as even their starting point, and we have to pay more attention to that. When we asked them then if they actually saw education happening, about 70% of the parents on medical ward rounds said, yes, we see it happening, and about 16% on the surgical ward rounds said they see it happening. So certainly there's a lot less visible teaching and learning on surgical ward rounds, which I don't think surprises most of us. When we asked parents, I guess, what then influenced their ideas about teaching and learning on ward rounds, these were the 4 things that came through. So they want teaching and learning to happen on ward rounds because they're altruistic. They believe that if they can help teach the next generation of doctors, then they are doing a service that's beyond their child. So that's their main drive. In addition to that, they really comment that the child still has to come first. So teaching and learning can't take precedent over the child and the care of that child. And again, I think that's really important to keep front and centre. Sometimes we can forget when we are talking and we are saying things in front of families. Sometimes we forget when we're trying to point things out in terms of physical signs or other things for that child. But how can we make the child come first while still teaching and learning? How can we get the job of their medicine out of the way before we take time, maybe at the bedside, to teach and learn? They describe the importance of the doctor and nurses setting the scene. And what I mean by that is actually at the moment in the ward round that you are going to do teaching and learning, or to flag it with the families, to say, we are just going to talk for a moment. This is so I can help, these young doctors learn. I want to know what they're thinking. This is a teaching moment. And that helps them, I guess, to understand that they don't have to listen to you in the same way, but also that if you are saying things while you are teaching and learning that might sound scary or upsetting or different to what they've heard elsewhere, that they know that that's part of teaching and learning and not necessarily relevant directly to their child. I usually flag that out as well. I usually say, you may hear us talk about things that aren't relevant to your child. You may hear us speak about things that you don't understand. And the final thing is that location matters. So the families that want you to teach and learn on ward rounds, we said, where do you want us to do that? Do you want us to do that in front of you, or do you want to do that outside the room, or before we come to your bedside? And it was a 50-50 split. So 50% of our families said, we want you to do the teaching and learning in front of us. We know you're talking about our child, so we want to hear everything you're saying. 50% of the families said, actually, we're pretty tired, we're pretty exhausted. We don't always have to hear everything else. If you can go and have that conversation somewhere else, that would be great. So what do we do with that? Well, I actually think what we do with that is what we try to do with patient-centred care. We try to do patient-centred education. We're going to do some teaching now. Would you like us to do that outside or inside the room? I'm hoping that our students can have a listen to your child's chest, but they seem tired. Is it okay to do it now, or can they come back later? So actually inviting the families to have some choice in when we have these teaching interactions and how we do them. So that's the parents. We looked at what the parents thought. Then we looked at what our doctors thought, both our consultants and our registrars and our training doctors. And this was the reality. And really the reality was quite different to expectations and beliefs. Our consultants, our senior doctors said, we teach all the time on ward rounds. This is our bread and butter, it's part of our job, and we are teaching all the time. Our trainees said, actually, we don't feel that we're being taught. We think the ward rounds should be a really key place where we teach, we learn, but we don't see that that's happening. No one's teaching us. When we looked at the ward rounds, when we actually observed them, we saw lots of teaching and learning, but there was no structure that held it together. The consultant was often what we call a stage, and by that I mean someone that's standing there and delivering information. Someone standing there and giving a mini lecture. And we know with our education principles that actually standing and giving information is one of the worst ways we can help people learn. People don't take it in. They remember very little of what you say. And so although you're standing and saying it, a lot of it is not retained. And this was so obvious in our setting that when I came to do teaching and learning on ward rounds, some of my other peers or colleagues would say, Amy's here to watch me teach, so I'm going to give you a 2-minute talk on this topic, and we'll just teach on a topic. Anytime anyone did that, at the end of the ward round, I went back to the student who'd had that mini lecture, and I said, what do you remember? And they said, what do you remember? What do you mean, what do I remember? I said, well, they gave you a small talk on that topic. Tell me something you remember. And they said, nothing. I don't remember anything from what that person told me. So this idea of being there and just transmitting information to your learners doesn't work. And it certainly... In our context, learning was implicit. So again, people assume that if someone follows them and observes them, they're going to learn the right things. Again, there's lots of evidence that that's not the case. So one of my colleagues, my peers, said, they watch me communicating all the time on ward rounds. So I'm assuming they pick up what I'm doing. And we know for a fact that's not true. So just watching and observing without any direction or sense doesn't lead always to learning. Our consultants, our senior doctors, whenever they did actively teach, it focused on technical content. What do I mean by that? I mean causes of diseases, treatments, the facts about medicine. It was really rare that someone stood there and taught about communication or empathy or understanding the patient's perspectives. Some of these things that are seen as the softer skills in medicine, and they're certainly not soft, they're core. But perhaps by us being there and always emphasising the technical skills, we're almost saying that that's more important than the softer skills, communication, and we can model that differently. The focus was always on students over trainees, so the minute the students turned up, people kind of switched into teaching mode. And I think the final thing is, which most of you will appreciate from your own settings, is that we're all time poor. The first thing everyone said to me when I said we're going to look at teaching and learning on ward rounds is we don't have time. It's too busy and we don't have time. What I'm going to take you through next, I hope, challenges that a bit and helps you think about how you can use that time more wisely. And you remember at the start I said we also looked at the evidence. So what is the evidence? Well, at the time I did this work, there was very little evidence around ward rounds. There was around 40 papers in 50 years. And you compare that to something new like a gastroscopy, of which there were like 30,000 papers in the same amount of time. So little attention had kind of been paid to this thing that we do every day, but there was some evidence. So we should use structures to help us to teach and to help our trainees to learn. We need to acknowledge the time limitation, but manage it, talk about it, and use that time wisely. We are only going to help learning if we target the learner's needs, so not teach what I want, but teach what they need. We have to encourage active participation, not passive absorption of information. And one of the key learning mechanisms is through reflection and feedback. And I'll get to that more in a minute. So knowing all this, what did we do? We put together this ward round framework. Right back at the start, I'm talking about ward rounds, but in fact, this can apply to any clinical setting and the same principles can apply. This is the framework, the website for it's there. The website actually has this framework as an interactive tool, so you can read a bit more about some of the things we talk about, and there's some video examples of some of the tools that I'm giving you today. If you scan that QR code, and hopefully I've done it properly, and that should actually take you to a web page where all of our information on teaching and learning on the wards is housed under our hospital banner. So have a look at that if this talk at all piques your interest. So why do we have a framework? We had a framework because we wanted to talk to our senior consultants, our busy senior consultants who already thought they were teaching and learning, and say, if you can just hold these 4 principles, you can keep doing what you're doing, but you can do it even better. And they said, that's fine, 3 or 4, no more than that. And so with 4, we came up with STICK. S stands for setting agendas and roles. T stands for targeting teaching. I for inspecting and reflecting on practice. And C for closing, and closing the learning in particular. I'm going to talk through each of these one at a time. And then when I finish, you've each got a chance to, I guess, ask questions either by unmuting and asking you a question or putting some questions in the chat. Let's look at each one, one after the other. So S stands for setting the agenda. What does that mean? Well, how often do you start a ward round with actually a plan for what's going to unfold? We often go to meetings with very clear agendas where someone introduces us, and we go to workshops where we have a plan for the next hour of what we're going to be taken through. But we could go on a 2-hour ward round to the other without actually talking about what we're about to do. So make the most of that time, have an agenda, and that's not just for teaching and learning, that's just good practice. So setting the agenda, what does that include? Well, it includes what do we need to achieve? How many patients do we have to see? What do we need to get through? How much time do we have? Are we going to be interrupted at any point? Do you have a meeting you need to get to, or something that's going to change what you need to do? But when we're thinking about teaching and learning, then think about, how am I going to weave teaching and learning into that? So what does the learner want? I could actually stop at the start of the ward round and say, does anyone have a question that they really want to cover on the ward round today? Is there a patient that you're really wondering about that I could stop and talk about more for teaching? Suddenly puts it in their court, and you get to know what they're thinking. I do feedback and reflection on ward rounds, and actually you need to prepare people for that. You need to say, look, on the ward round today, I'm going to get each of you to be the person who leads with a patient, and afterwards I'm going to take a minute for you to reflect on how that goes, and we can give you some feedback. Preparing the person that's going to happen on the ward round is actually a really important thing to do to make them feel safe, but also to check with them that that's okay. And even simple questions like, what would you like to get out of the ward round today or this week? What can I do to help your learning? There's not always questions we ask, but I encourage you to think about where you could insert them on and how. These are also questions that can help you when it's really busy. There are days when I turn up to the ward and I know there are too many patients, and I know there's a sick patient, and I know I'm going to have to navigate that and put teaching and learning to the side or reduce its priority. But I can also say that to my team. I can say, today's really busy. I'm not going to have as much time to do some active teaching, but if there's something you really want to know about, you need to let me and we'll talk about that. Or if there's something you don't understand, and let's clarify that and see how we go. So that's setting the agenda. Then there's setting roles. Again, how often do we do this? I'm hoping you do it a bit, but more often than not, the senior person starts and then the junior people follow. This was so evident when I was actually observing ward rounds that even though I was observing and not a member of the team, none of the junior doctors would walk into the room before me. So I had to start to encourage them to walk in before me and hold the door open for them. And actually some of them I had to push them in before me because they weren't going to walk in before me because they were used to a hierarchy where senior doctors walked into the room first. So who's going to lead? Who's going to examine the patient? Who's going to write the notes? These are tasks that are traditionally given to one member of the team or another. But if we can rotate these jobs around, we suddenly get all our team members being active. We get a chance to look at the most junior person in the room who is interviewing the patient or examining the pick up where there's room for improvement in their skills. So think about who is doing the work and how you can share that work around, because that is how they're going to learn best. I think it's particularly striking in our hospital that our junior doctors are the ones that write our notes and they're stuck behind a computer. But when I leave the ward and that patient gets sick and they're called back to see them, they're the one that has to reassess them. And so if I haven't helped them to assess that patient in the morning, or they haven't heard or actually seen the physical sign they have to review later, it's really making their job hard. So think about who needs to do what and how you use that time. And the final tip I'm going to give you under setting the roles is the use of something called intentional modelling. So intentional modelling is the idea that you give someone something purposeful to observe. This is really good for medical students. Medical students without a good idea of what they should be doing, watching, or listening to. So that might be an example of intentional modelling in mind. We're about to see 3 babies with bronchiolitis. For each of those babies, I want you to look at them and think about how you would assess their work of breathing, whether it's mild, moderate, or severe, and why. And then when we come, and you're going to make a judgment about that. Now, to take it a step further, I'd be saying when you come out of the room, I'm going to ask one of you to tell me what you thought and why. So give them something to observe, because without that, there's actually so much they could see that they often miss what they really need to pay attention to. So that's setting the agenda and setting the roles, the first part of the framework. I've talked about it for a while, but this can take about 2 minutes, even less. The second part is targeting teaching. And there's many ways to do that. And what I don't want you to walk away from is here thinking you have to do all of these things at once. You need to have some things in your toolbox, and you need to understand when you can pull those things out to use them for the best effect and to make your job easiest, but actually to make the learning the best. So on our tool, we've got a few suggestions. The 1-minute preceptor I'll tell you about in a second. Active observation is a bit like the intentional modelling I just described, but with that follow-up. So I want you to watch this, and then afterwards I'm going to get you to tell me if you thought the work of breathing was mild, moderate, severe, and why. And I can tell you, if you tell a medical student to do that, or tell 3 medical students to do that, they're going to pay much more attention to in the room than if you said nothing and they just had to go in and watch. Suddenly they're all attending, they're all thinking, even if you're going to only ask one of them afterwards. And the final thing I'm going to touch on is effective questioning, because actually the best way we can target our learners' needs is to ask more questions, not speak as much. And that's challenging, but it's one of the most important skills you can learn. Lagging a bit. Yeah, there we go. The 1-minute preceptor is about getting clinical reasoning, understanding someone's clinical reasoning. And there are 5 steps. And you only succeed in getting it down to a minute if you concentrate on each step being what it needs to be. So this is not about someone doing a full case presentation, telling you all the history, all the exam. This is about picking one aspect of that you want to focus on to talk about. So it could be that they've seen the patient and you don't really care if it's accurate or not, but you want to say to them, what do you think is the most likely diagnosis? That's a commitment. What is the most likely diagnosis? Then the step 2 is you probe for reasoning. Why do you think that? Why didn't you think that? What else did you think about? And why do you think they were less likely? This is where you're going to spend the most of your minute, just probing around to decide why did you decide that over other things. Then finally, you're going to say what they did well. Yes, I agree. I think that's the most likely diagnosis, and I think you were right to pick up on this part of the history. Then you're going to correct or suggest something else. I did wonder whether you should have also considered this as an alternate diagnosis, or I think you maybe missed out on this piece of information. And then finally, you're going to try to say, give a learning point that they can take to the next time they see a similar patient. And that's kind of the general statement of like, whenever I see a child, again, I'll use bronchiolitis. Whenever I see a child with bronchiolitis, I always consider X, Y, Z. I always consider a secondary pneumonia when there is a new fever. It can be triggered in someone's head next time they see a similar patient. So this can take a minute, and it can be a really good way of almost diagnosing and thinking of someone's clinical reasoning, but you need to keep it to the point. So start with a commitment, probe, one good thing, one correction, and then one learning point. And the commitment, like I said right back at the start, doesn't have to be a fact. What's the most important diagnosis? Do you think is what might be the most useful investigation? There's many different things we can think about what the commitment might be. So that's one tool. Think about a bit of a play with. If you look at our online tool, you'll see a little explanation of the 1 minute preceptor as well as an example video. But if you Google the 1 minute preceptor, you'll see lots of examples. It's perhaps the most best studied teaching tool in terms of evidence for it having some value in teaching and learning. But my second favourite teaching tool, and probably my most favourite teaching tool, is effective questioning. And I put this slide up because I think this is what a lot of our trainees look like or our students look like when senior consultants ask a question. Many consultants ask questions that leaves the trainee thinking, what are you thinking? I know you're asking, it's like that, please read my mind question. I know this topic, but I can't work out what it is that you want me to say. So how can we avoid that, and how can we make the most of questioning? Again, while I'm talking, I just want you to think in your head, and some of you may be close to being students now, some of you may be further away from that path, but we all have memories, and even if you're a trainee, you probably have a memory of what it's like to be questioned by a senior person, a consultant, a registrar, even a resident, by a junior resident. If you're anyone more senior, there are these memories of being questioned. And a lot of the times I'm told by our junior doctors that, look, I'm asked a question and I know many answers, but they ask me this question, I think, I don't want to get this wrong. I don't want to look stupid. Okay, what could it be? Well, it could be this, or they could be talking about this. And so their head starts to go into this thinking mode of what answer are they looking for? And if they don't come out with something fast enough, they're often cut off and someone gives them that mini lecture or gives them the answer. And they think, I knew that. Why didn't I just say that? And these are the stories you often hear if you talk to junior doctors about their experience of teaching and learning. And so how do we move past that to something that feels a bit more productive, that something perhaps that feels more encouraging, not threatening, and how do we make that experience better? I put the second question there of what types of questions do you know? We all know open and closed questions, but there are so many other types of questions that we can use in our day-to-day work, and sometimes I think these get forgotten. I'm going to put them up now. So these are a whole range of questions. It's open and closed. There's probing. There's, why do you think that? Tell me what made you think about that. Does this make you think of a different diagnosis? So probing into someone's understanding or someone's thinking. There are reflective questions. How do you think that went? What did you think of that feeling in the room? How do you think we're going in this case? I'm feeling a bit uncertain. So there's reflective questioning. Clarifying questions. So that's, you know, if someone says, I might start this medication and see if it works, your clarifying question may be, oh, do you have in your head how long that would take for that medicine to work? So, you know, again, just trying to nut down in details, but in kind of a gentle way. Peer questioning is something I use quite a lot, and I'm sure many of you do without even knowing what it is. But when actually getting the peers to ask the question or to move up through the different types of trainees or students on your round, from the most senior to the most junior. So you ask the first question to the most junior, and if as they exhaust their knowledge, you move up and up to different people. That can be a really good way of seeing what the breadth of knowledge in your team is. And if your most senior member can answer all the questions, then my job is mostly to encourage them and say, that's exactly the response I would have given. I'd also think about this. So to actually, or sometimes I frame it in this way, so to add I guess the nuance or a different perspective. Some people find peer questioning hard because you have really junior, a more senior who doesn't know as much. How do you balance that knowledge? And I think that's something we all have to be conscious of when we get into peer questioning. Hypothetical questioning can be useful if you're seeing lots of the same things and you want to kind of vary it up. So if I am seeing lots of kids with bronchiolitis, my hypothetical question might be, well, if the story wasn't that, if the story was this, would that change your mind? So changing the situation to see how they would respond would change, or would their thinking around the diagnosis change? And leading questions, we all know, there is sometimes a role for leading questions, but in general, I think the leading questions are the ones that half of our trainees think, what are you thinking, and what is in your head, and it's the guess what's in my head question. So I want you to think about that range of questions as you're questioning someone next time and thinking, are there different questions that I could use? And my final tip on questioning is these 3 rules. So number 1, if you want to actually target the learner, ask the question, don't tell them the information you want them to know. So where you can ask, try not to tell. Wait. Now, some people talk about pose, pause, and pounce, the idea that you pose a question, you pause to get a response. We know the time you're meant to pause is about 5 seconds. Now, that's a long time to wait in a ward round. But if you don't wait, then people's thoughts are still going and they're not going to have a chance to talk. And then pouncing is the idea that you then might call on someone to speak or name someone to speak. Now, I don't like pouncing so much. I find it a bit threatening. But certainly waiting and giving people time. And my final tip, and probably my most important tip, is if you ask a question and it falls flat, if there's no answer, if you've waited 5 seconds, before you jump in and answer it yourself, maybe just ask one more question. Maybe just give them a chance to tell you what's gone through their head in the meantime. They might be sitting there thinking, oh, I don't know, which way does she want me to go with this? And instead of you giving the answer, say, is anything going through your mind? Did you think of any options? Or framing your question in a way that might help them start to sort through it. All right, so you're not sure what the diagnosis is. What kind of big problems can you think about, like inflammation, infection, malignancy? Let's get through it that way. So ask a question. Ask if you can ask. Don't tell. Wait to get a response. And if you don't get a response, just ask one more question. If you can ask one more question, I'm sure you'll improve the learning. So that's targeting teaching, and I'm getting onto the fourth part, which is inspecting and reflecting. We know feedback is one of the most important parts of learning, but it's really hard to do in, I guess, a workplace setting where everyone's around you and you're working out when it's appropriate and when it's safe. When I started to talk about ward rounds years ago, I really focused on feedback because I thought it was essential. And I still think it's essential. I think you can set up people for feedback on ward rounds and give really small pieces of feedback well that make a difference. By asking things like, how do you think that went? How did that feel? That was a difficult conversation. Tell me, what you think you did well. But I actually think mostly what I'm doing now in doing that is getting them to reflect, encouraging them to reflect after we've done some work together so that we can start to talk about how things go and what can improve. So try to get to feedback, but if you can't, start with reflection. And why I think this is so important, I give this example often. We often have, I guess, shifts and other things in our hospital where one junior doctor may work on one ward for one day, and they may do that day each week and do it for a year. But us as senior doctors, we may do 1 week on that ward, and so that person may only once or twice a year. And then see all the other senior doctors once or twice a year. So then they're not seeing anyone regularly enough to get feedback. They're not seeing anyone regularly enough to actually hear what they'd be doing differently. So if I don't give that person feedback on the one day I work with them, then I don't know that they get any at any time. So I really, when I was working in that ward, I really made it my job to try to say, okay, I'm going to try to give each of these people one piece of feedback each day, each day I work with them. And I remember this particular case because it was the end of the year and about 30 weeks into the year, and I said to this junior doctor, I'd like to give you some feedback. She said, that's great, please give me some feedback. And I said, you first of all, I want to tell you what you're doing well. This is what you're doing well. She said, I know I'm doing that well. I said, oh, good. How do you know and why? And she's like, well, last time you were on the ward, you gave me this small piece of feedback and you said this is what I could improve. So since then I've been working on it and now you're seeing what I'm doing. And I was like, that's amazing. I think I spent 2 minutes talking to you 30 weeks ago and you've picked it up and run with it and now you're doing it really well. So don't underestimate how much well-placed, well-delivered feedback can do for someone who doesn't actually get much feedback in their job. So, and I think that is a lot of our trainees. So well-placed, well-delivered feedback doesn't have to take long and can make a difference. Oh, and I've missed one slide. That's funny, it's disappeared. Oh no. As I said before, reflection is the key. So aim for feedback, but if you can't get to feedback, encourage reflection, encourage it amongst your team and demonstrate it yourself. So as the most senior person on the team, on a ward round, I will try to come out of an interaction and say, gosh, that was awkward. How do you think I went? Demonstrating to my own team that I'm looking for feedback too. So reflection is the key. And the fourth part of the framework is closing. I'm sure lots of you think about closing the clinical, making sure we all understand the plans for our patients, but how do you close the learning? And this is one of the most easy things to do that can make such a big difference. So at the end of a ward round, could you spend a minute just saying, this is what I hope you've learnt today, naming the learning, labelling it. Even better, and this is actually the tool I use the most, what did you learn today? I want you to name one thing you learnt today. When I first did this with medical students, I didn't give them any warning. At the end of the ward round, all I did was ask them, I want you to tell me one thing you learnt today. So much. We learnt so much we can't think of one thing. And my heart broke slightly because we'd been doing teaching, we talked about lots of topics, they'd asked lots of questions, and yet by the end of the ward round, I couldn't name one thing they'd learnt. And so the next day, and I just think that's a shame. I think if that's the time we have to work together and learn together, and they're not going to suddenly walk away from that ward round and think, oh gosh, I learnt that. They're not going to have a realisation 1 week later. So if they're not learning it then, they're not learning it. So the next day I started the ward round, and in my agenda I said, at the end of the round I'm going to ask you one thing you've learnt. That's part of my agenda. And that day they each had a list of 3 things that they'd learnt. And the next day they had a list of 5 things that they'd learnt. And one of them by the end of the week had a list of 10 things, 20 things, 30 things. He had a whole book. And I guess what I could see is that just by asking one simple question, suddenly I'm encouraging these students to be conscious of their own learning and their own list of learning as they're going, making them self-directed learners themselves and reflective learners themselves. So if you can do one thing, that's the thing I'd encourage you to do. Ask people what they've learnt after they've worked with you. It can be pretty humbling, maybe the first time you do it. So that's the framework. Set the agenda, target teaching, inspect and reflect, and close. And you're probably all sitting there thinking, gosh, this is a lot. I can't do this all the time. And you don't have to. It's a hard thing to change habits if you're doing something already. It's a hard thing to change. We are all creatures of habit, and changing our habit is hard. But what I encourage people to do is at least set an agenda and close. Because if you can do that, everything in between is better. And on your good days, start to use that toolkit of teaching to start to try different questioning or using the 1-minute preceptor. And on your best days, make sure there's reflection on your round and a bit of feedback. And none of that can happen. Why should we do this? Well, it actually works. So we put this framework into action in our general medical department, and this is what we found out. We heard from consultants who had said, nah, we're not going to be interested, that this was useful, feasible, it was really hard, but they found a lot of value in taking this on. Our teams actually said there was improved participation. This is our junior doctors. We're participating more. We have more clarity of both our learning, and we have better teamwork. So we impacted teamwork by trying to talk about teaching and learning. And most critically, our senior doctors said this is not taking us more time. Less, because we were trying to do too much before or think about ways what to teach. And now we're being driven more by our learners, and it can be easier. So if it feels hard, remember evidence. And so now I want to close. You'll have a chance to ask questions in a second, but perhaps if you're feeling brave enough, or you'd like to comment, what's one thing you learned? If you're going to walk